All right, thank you so much for the invitation to speak today on a recent student project that one of our genetic counseling students did, looking at parental experiences with genetic counseling really throughout the newborn screening process, but most specifically for those parents who have a true positive or an affected child after newborn screening. And kudos to the planning committee on putting this right after Samantha's talk, because I think we're gonna see a lot of what Samantha talked about pulled through in additional themes here. So I think this will be really nicely complementary to what we just heard. So let's see if I can do this. So for my portion today, I'm going to really give some brief background on genetic counseling and newborn screening. I know this might be a review for many of you, but just kind of level set us on what we're talking about. Then I'll talk through the study results and then some of the next steps that we will be embarking on as a result of what we heard throughout this study. So one of the first things you learn when you become a genetic counselor is how to explain what it is to be a genetic counselor. So genetic counselors, as I think many of you know, are really integral parts of a genetics team or a disease-specific team, as is the case for XALD. So our job is really to help to identify underlying causes of the disease, which is usually through looking at family history or facilitating genetic testing, and then helping to interpret those genetic testing results in the context of what is going on both with the child as well as with the family. We also counsel families, which is a little bit different than what you might think of in a typical kind of counseling session. It's a mix of providing scientific and medical information, as well as some of the kind of psychosocial things that go around genetics and getting these results back. We do hope to determine if other family members are at risk and need to be tested as well, and we can help facilitate and coordinate that family testing, which we often call cascade testing in the world of genetics. And then we provide support and resources. And this graphic here is just from the University of Minnesota, talking a little bit about how genetic counseling fits into their specific XALD clinic. And when we think about newborn screening, I think many of us think primarily about kind of that middle piece there. So we think about the idea of collecting the specimen either in the hospital or at home. We think about running the tests and getting results. Those can be negative results where we're kind of done, we don't do anything further, or they can be results that are what we consider actionable. We need to do further work on this. Those actionable results get sent to clinical evaluation in many cases, where we then can determine, ideally, if this result is what we would consider a false positive result, the child is actually unaffected, or a true positive result, the child receives a diagnosis and we need to go on from there. But as you can see, the newborn screening journey is really just a part of a broader patient journey, especially for those who do have a diagnosis. And throughout this journey, there are multiple roles that a genetic counselor could play. Certainly we can be involved in that initial kind of clinical evaluation piece, but also in thinking about decisions around initial treatment and management, decisions around ongoing treatment and management. We can help facilitate things like transition to school, which can be a very difficult transition for many of our genetic diseases, transition to adulthood, and of course, working with that family and even that eventual child on reproductive considerations, which shoots us back into the prenatal period and potential for newborn screening. So I like to always level set that newborn screening is not just in a silo, it is really part of a broader kind of diagnostic patient journey. So the purpose of our study was to really explore the role of genetic counseling in the newborn screening space, considering that longer kind of vision of what newborn screening really is and how it fits into a long-term patient journey. We wanted to understand the differences that parents feel when they're thinking about a newborn screening diagnosis versus a clinical diagnosis. This is something that we often forget about, that parents who are getting a diagnosis through newborn screening are coming at it from a very different standpoint than a family who's been experiencing symptoms in their child. Newborn screening families were probably told that their baby was perfectly healthy, that they were ready to go home, and then they get this call. And that is a very, very different way to get a diagnosis. And we have to think differently about how we approach and support families getting diagnoses that way. And then we wanted to really elucidate what were the experiences of these families through that newborn screening process, and what are some of their preferences for timing and speaking and engaging with genetic counseling. We chose to focus on 3 of the kind of newer RUSP additions. So we focused on Pompe disease, and we chose that because Pompe disease does have a pretty wide spectrum for clinical symptoms. They have an infantile onset and a late onset, which we really can't determine very well at the time of screening. We chose to look at spinal muscular atrophy as well, and we know that there are a number of treatments available to them. We thought this would also be unique in that SMA is often carrier tested for prenatally, and so there may be some prenatal testing or prenatal genetic counseling exposure by those families. And then, of course, XALD, which I'll be focusing on today. We thought that this would be really important because, again, also the variability in spectrum of disease. The fact that it's X-linked highlights the importance of thinking about family members and getting family members involved and tested, and then also thinking about unique considerations around those that are male who have positive screens and those that are female who have positive screens. So our methods, we went through a period of recruitment where we relied heavily on patient advocacy organizations. So thank you, Miranda and Elisa, for helping us with this. We did an initial screening survey just to make sure parents who were interested met qualifications and were eligible. Those that did went on to have Zoom-based interviews. We then coded those interviews and provided, and then performed data analysis. So we ended up with 13 participants, and I know that doesn't seem like a long number or a big number, but for a genetic counseling project that's about 9 months long, this was this was pretty good. We had 5 XALD parents, 7 Pompe parents, and 1 SMA parent, and each interview lasted around 45 minutes. This is just quickly a table of our participants. You don't have to memorize this by any stretch of the imagination, but I want to highlight a few things. So all of our participants were mothers, and you can also see that we lacked diversity, and that is something that we will be focusing on later on. As we went through and coded our interviews, we identified essentially 5 themes that really came out in terms of areas of experience and areas where we could focus on doing better in the future around genetic counseling and newborn screening. So the first was newborn screening and results disclosure. The second was the diagnostic process after newborn screening and that kind of prognostic journey. The third was issues around treatment and follow-up. Fourth was communication, and that was communication both between providers and between the providers and the family, and then this need for holistic support after newborn screening. And so I'm going to dive into each of those themes in more detail in the next 9 slides or so, really using quotes to illustrate more what we learned and what we need to think about. So the first was this background knowledge of newborn screening and results disclosure. And you can see in this first comment that this family felt like there wasn't a whole lot of information on that initial phone call, or even why newborn screening was done. And I think this is really important to remember that a lot of families are not even aware that newborn screening was done, and now you're getting a result on a test you had no idea happened. And so we're really starting from that baseline when we are providing results, and we have to remember that when going into it. The second I wanted to pull out, because I swear to God, if I see anyone else say, don't Google it, one more time, I'm gonna lose it. That has a success rate of 0%, just so you know. So if you're gonna say it, if you feel like you have to say don't Google it for whatever reason, you can say that, but say, don't just Google it, go here. This is where the information will be most up to date. Give them a place to actually go. Because saying just don't Google it, that's a very isolating comment, because what are you supposed to do then? Where are you supposed to go? How else do you get information? And so this is something that really needs to be worked on at a global level. This is something we hear far beyond XALD. We hear this in many of our other disorders. This was an interesting discussion around the workflow, and I think this again gets to the importance of thinking and remembering that these are screening results, and we don't always get a clear kind of even negative or positive result. And so this was a situation where this family had a result that was quote unquote inconclusive or maybe borderline, and they were told, okay, we need to test again. And again, we're never told why they need to test again. So they were thinking, well, maybe there wasn't enough blood. They weren't told that something was flagging. So they do the test again. It's inconclusive again. And so now they need to go and get local or diagnostic labs. And at no point during this journey were they told something might be wrong. I think they were thinking the whole time that it was largely a sampling error. And I think this is important for us to think about because we do have these results at newborn screening, and we do try to balance these results. And I think when we're thinking about how to communicate these, we have to think about balancing not over alarming anyone, but not also under alarming. And I think Stephanie said really nicely that, knowledge is power, and you can handle, parents can handle this information if it is provided in the right way. And so I think we need to be okay to say something is flagging, we want to take another look at it, but not just pretend like this is going to be nothing, because it might not be, as was the case here. We did talk a little bit with our families about what should this look like. And for those of you who are in the newborn screening space or have experienced the newborn screening space, you know that a lot of programs rely heavily on the primary care provider or the pediatrician to relay this information. And a lot of parents have been questioning, we've seen this in focus groups as well, is that really the right person? And I think many of us would say no, because they don't have the familiarity with this disease. And so what we've heard from a lot of parents is that they don't care whether or not they have a relationship with the person providing that information. They just want that person to be able to answer questions and understand how to give results in a compassionate way. And so I do think this is something we fundamentally have to think about in newborn screening is, are the right people actually notifying the results? And these people both need to have an understanding of the screening process and the disease, and have some ability to do and provide high anxiety news. So let's talk a little bit about the diagnostic process and the prognostic journey. And this was really around timing. And I think this is particularly interesting and something we need to think about in the XALD space. So this was a family who got, I think, their result on a Wednesday. And we're told, okay, your appointment will be Monday. And they tried to call and talk with someone before then, and we're told, no, you can wait till Monday. And one of the things from a healthcare standpoint, especially in the United States where we are very backed up in genetics, is that thinking, wow, it's Wednesday and you're getting already in on Monday, that feels like a really short time to us as healthcare providers. That's really fast. But that is 5 days of trauma and trepidation and confusion for families. It's a lot of time to go through, especially if they're told don't Google it or they weren't provided resources. And so this is an area where, again, I think we really need to be thinking about how to support families in that unfortunate but understandable period of you get the result to when you can actually see someone who knows what they're talking about and knows this disease. I'll talk a little bit later about some of the work that we're going to be doing and trying to accommodate that. This was a quote around kind of that initial appointment, actually. And this was really interesting, I think, in that they talked about how when the condition was being explained to them, it was really kind of explained in the worst case situation. They didn't feel like they were given a sense of hope. And I do think sometimes this happens because these are very serious disorders, but we have to remember, and I think we have to share with families that there is a reason that we are screening for this. And that is because there is something we can do about it. I'm not saying give false hope, but what a term that many families have provided to us is we want evidence-based hope. Give us hope that is rooted in the evidence that we can kind of hang on to as we're going through. And so in this situation, this family said, they were never told that they could have something less than cerebral disease. And so I think, again, being able to provide the spectrum of information is really important. I thought this one was really interesting as well. So this is actually from a family who I believe was the first family in their state to be identified on newborn screening. And I thought it was just beautiful that they felt like, we had to actually give grace to the providers. And I think it is hard when you're first screening for a disease and you are the first one, you're not really sure how to you haven't had the experience of providing these results. And that can be very hard on the provider as well. This family said it was clear they just didn't know how to relay the information that she had a positive screen in a way that parents should receive this. What this highlights for me is that when we are thinking about implementing new disorders or even improving upon our existing disorders, we have to step outside the laboratory. We focus so much on the laboratory, the reagents, the algorithms, what are we testing for, what are our cutoffs, but we forget about what happens after the results leave. And we really need to prepare our families and our providers on how to provide this information. Pivoting now to treatment and follow-up. This was a family who really talked about how long that this can take. And it was really 3 to 4 months before they found out that they were even dealing with adrenoleukodystrophy and all the support they needed in making sure that the mother got tested before their other children could get tested. And again, I think this is something that we have to think about in terms of making sure families have that support by genetic counselors to help them walk through this process of not only testing the child, but also testing additional family members. And here in treatment and follow-up again, and I think this gets back to how quickly I think we do need to get specialty care involved in our follow-up instead of often relying on the pediatrician or primary care to navigate and do this. So this family said, if I could do this again, I would have reached out to the specialty clinic way earlier to get these answers. And they felt that even, their pediatrician actually knew a good amount about ALD, but just not as much as they really need at that moment. So again, I think we need to figure out how to get specialists, or at least people who know this disease and know the answers to questions to families much quicker. The fourth kind of theme was this theme around communication between providers and families, as well as communication between the providers. And we heard quite a bit that there just seemed to be a disconnect. We know that there's a number of different specialty providers that need to be involved in the care of ALD. And you can see by these quotes that families often feel like they're not getting communication, or in one case, the physician said, I don't even know why you're here. You tell me while you're here. And that's a terrible place to put families in when they're dealing with something and now they have to also educate why they're even standing in front of you. So again, this gets to back to the importance of having coordinated clinics and really equipping the providers to understand what follow-up is going to look like. And I'll end with talking a bit about the holistic support. So again, newborn screening results are not happening in a vacuum. There is a lot going on in these families' lives after newborn screening, especially when they have a new baby in front of them. So these two highlighted the importance of advocacy organizations like ALD Alliance and having support groups give out information, having somewhere for families to go where they don't feel like they're alone and they can see what's going on with other family members, someone to talk to that's been on this journey as well. And then the last one is remembering that this this, again, is not happening in a vacuum, that there are a lot of things going on. And I think sometimes we are so focused on the success of newborn screening and how great it is that we've picked up a child early that we forget that we also are causing trauma. And we can have both things. We can be making a huge difference and we can be causing a traumatic reaction to families. And how do we support them in understanding that, especially in a postpartum perspective. So I know I threw a lot of quotes at you, like a significant number of quotes at you. And I want to take a step back and say these types of studies and these types of stories, they matter. I think sometimes we look at qualitative data like this and go, I can't put that into a spreadsheet. I can't put that into numbers. But studies like this are really, really important because there are some things that just simply can't be counted, but are still really important. So I think anecdotes like this matter because they give us signals of what might not be working before we have a chance to generate more of that quantitative evidence. For me, this shows a lot of gaps in areas of the newborn screening process that we can work on. It provides the human side of the data. I often say that, data opens doors to change, but it's the stories that walk through those doors and make the change. And so this really helps us put that human side to some of the data that we're seeing. It does help us generate new hypotheses that we can further research and look into. And there are just some things that simply are outside the limit of measurement. I think trauma, trust, pain, those types of kind of human emotions can be very hard to accurately measure, and so stories really put that into light. So what we learned from this study is really threefold. In terms of the genetic counseling role, really, I think genetic counselors need to be involved earlier, including in the potential for result disclosure, helping educate providers who may be part of the team, and being a conduit to some of the care that is needed, again, especially with XALD. From the newborn screening perspective, I think we absolutely need to improve communication. I think I've been in newborn screening now for 20 years, and I think I've been saying that for 20 years, but we still need to do that. Providing support resources as well during that diagnostic follow-up time. And really, with keeping our future families in mind, we need to strive for balanced and up-to-date information and resources that are provided to families when they need it and how they want it, and start thinking more about the holistic supports that are needed from the beginning. And when I say the beginning, I'm saying from that moment that result is communicated out. So we do have some additional studies that are kind of pulling from what we learned here. So we do have a kind of result notification study that we're working on right now. That's in collaboration with Expecting Health and Natasha Bonham that Michelle quoted a couple times. So we are really trying to look at really in depth of whether the current model of result notification makes sense. So we have been surveying newborn screening programs, clinicians, and genetic counselors on practices, and we will be developing some new notification recommendations. We also have been participating in looking at the role of potential AI and chatbot use in that middle period of result notification and diagnostic. Can we provide some very curated, not ChatGPT, like we will provide the information, ability for families to ask questions, especially in the evening or weekends when it's hard to get a hold of specialists. And then the second one is really starting to provide some guidance for genetics clinics around trauma-informed care. This has been woefully lacking in genetics and rare disease. So we do have a collaborative that has been putting out some webinars, helping genetics clinics and transplant clinics incorporate trauma-informed care practices and assess kind of where they are at that, and assess how to talk with parents about that and assess if they need further resources. So with that, again, this was Macy's project. I'm just speaking on behalf of her. She moved to Hawaii, which apparently is lovely. So here I am. Erin Goldenberg, Michelle, and Christina, they're all out of Case Western. Of course, members of the advocacy organizations, Miranda and Elisa, thank you so much. It's really great when groups support projects like this and student projects like this, and I hope you can see all that will come out of it. But most importantly, of course, the parents who sat with us for 45 minutes and really laid bare their journey. So with that, I'm happy to take questions for 3 minutes, maybe. Thank you.
Hi, I'm Julie from Kennedy Krieger, also a genetic counselor. Thanks for that talk. I think a lot about this, of course, I'm sure we all do. And I've thought about, can newborn screening programs, when they send the results to a pediatrician, include a script, a suggested script for what to say?
Yeah, so we actually created a document like this, and we rooted it in some of the oncology literature on how to provide high anxiety or bad news. So we did, and I'm happy to share that with you. We came up with our own protocol called SCREEN. I know. Brilliant, but really talks about not just what to say in terms of the content of the disease, but how do you actually say this, and how do you check in on whether they're hearing this, whether they're absorbing it. So I think Stephanie, you mentioned, we've all gotten traumatic or bad news, right? And what happens? Your brain shuts down, almost immediately. And so we've been trying to do that. It's a little bit hard to tell healthcare providers how to communicate. It's a balance, but we do have a sheet that we've been trying to encourage programs to send along with their fact sheets that does try to say hey, we know you don't provide this type of news very often, here's some suggested ways to go about it. Yeah.
Love it.
Yeah. All right, thank you.